Assalamu alaikum wa rahmatullahi wa barakatuh. Sabahkum Allah bil khair. Good morning, everyone. It's delighted to have you again for the second day of the Saudi Neonatal Society Conference 2025. We're very excited to have our distinguished international speakers join us today. We've had Dr. Joseph New join us and also Dr. Alex Sharma. Today is going to be a quite heavy day. We have a full scientific program that we're going to talk about innovation, respiratory care, and GI as well. We have in the afternoon a vascular access workshop. So it's going to be a full day. And we're happy now to start our first session. Now, Dr. Imad Khadawardi and Dr. Fahd Sfayan will be moderating this session. Dr. Imad, well-known consultant neonatologist. He's the CEO of King Faisal Specialist Hospital in Medina. And Dr. Fahd Sfayan, dear friend of mine in the Eastern region. He is currently the head of the Neonatal Intensive Care Unit and consultant neonatologist at Sulaiman Al Habib Hospital. I'll leave the floor for you to continue. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. It's a lovely day. It seems to be also bad traffic because probably we'll have more in the coming few minutes, inshallah. Today is appealing and attractive topic as it discusses something very pertinent to each discipline, and it is evolving very fast, and us as a busy clinician, we have to cope with that on a timely matter. It's an innovation in neonatology session, and we'll start with AI in neonatology to be presented by our guest speaker, Dr. Jubara. So they did not send me Dr. Jubara profile, so I asked ChatGPT, although I know her very well. So let's see what did ChatGPT said. But you have to be careful. She will tell us what's the limitation. So it said Dr. Jubara is an assistant professor of pediatric and consultant neonatologist at King Saud bin Abdulaziz University, Jeddah. She also served as King Abdulaziz Medical City National Guard Health Affairs Jeddah, the neonatal department. Previously, she held roles such as Director of Neonatal Fellowship, Training Program, and Coordination of the Saudi Perinatal Neonatal Fellowship. If we forget, we should not forget her effort in the Saudi NRB establishment and monitoring and training. Dr. Jubara, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. First of all, I would like to thank the organizing committee for inviting me to be with our lively SNS conference. And really, it is a pleasure for me to talk today about a very interesting topic to me since like 2022. I get really excited about the AI in general and in neonatology. So I will talk briefly about AI in neonatology. AI in healthcare, you need days and days and workshop. And I hope I can just summarize briefly in this next few minutes. So to start with, I have nothing to disclose, except most of my presentation, I use different AI tools in the graphs, tables, and in other way. So let me start asking you, do you think AI will be our future in healthcare system or in NICU? Yes or no? Yes. Okay, it depends actually. It depends on us. AI is really the future, but it's a tool. I give it an example like a kitchen knife. Everybody has a kitchen knife in his home, and this can be used for preparing food, but at the same time it can be used for harm things. like killing people. The same for, yes, stabbing someone. Or the same for a razor used for shaving, and it can be used also to cut your throat. So it's a tool, and its use, it depends on us. So let's start by some definitions. So what is artificial intelligence? Artificial intelligence is a wide branch of a computer science that dictates to build system. The system will be capable of performing tasks that typically require human intelligence. There is an important 4 component in the artificial intelligence, like learning, the ability of the machine to acquire and adopt knowledge from data. Second, reasoning and problem solving, which make a decision and finding a solution for a problem, for example. Perception, interpretation of sensory input, like vision, sounds, and the language. Understand and generate human language, like video, sounds, clips, and these things. So, AI is not a ChatGPT, okay? So, AI is the big model, and it's not a new. If you look to the literature, it's from 1950. Artificial intelligence is existing. And artificial intelligence involves technique that equipped computers to emulate human behavior, enable them to learn, to make decisions, and to recognize patterns and solve complex problems and issues. This is the big. There is a subgroup or subset of it, which launched in 1990s, and it's called machine learning. Machine learning is a subset of the AI which use advanced algorithms to detect pattern language data sets, allowing machine to learn and adapt. A big example like Netflix. If you see one movie, next they will suggest movie according to what they thought. The machine learn what your preference. The same for Amazon. If you get you purchase something in Amazon, they will suggest something similar to what you used before. Then deep learning has been looked at into 2010, which is also another subsite where they use neural network in-depth data processing and analysis, like using a human brain. And this is used very dramatically in Tesla, self-driving car, or face recognition in iPhones. So this model is generating like a human brain. Then 2020s, the new things like coming to the era, which is the generative AI, or what we call it Gen AI. And Gen AI, like it's a subset of deep learning, but that generates context like text, imaging, code base. So you ask the machine to create an image from zero. I want an image like I did in my presentation, in ICU with like a doctor, baby connected to ventilator. So the machine will create that to you, or generate that to you. And you know, in November 2022, there was the ChatGPT was born. And you know, in the first 5 days, there was almost 1 million prescription or online user. And then as another subset, which is the large language models, which is a machine learning model that comprehend and generate human language text. So you don't need to type. So they generate or they recognize the human language, and they generate it in a different language. And there is a lot of examples like ChatGPT, 3.5, 5, Gemini, Cloudy, Meti, and others. We have a lot of examples. So just example about ChatGPT. How many of you using ChatGPT? By raising hand? Everybody. I think everybody. If you go even to school, even children, they use ChatGPT. So really in November 2020, just imagine in 5 days, 1 million user. 2 months later, 100 million user online ChatGPT. And you can see it's really increasing. And by August 2025, imagine we have 700 million users of ChatGPT. So that's really huge number. So how machine learning works? Simple overview, I will go. So it collects clinical data. So everything is data. You fill the machine with the data, then cleaning, labeling, and preparing data. Train that model for the data. Again, test and validate that model. And if there is something you need to adjust, you need to go back to the data and they adjust it, and then refine a model, and that model can be integrated into healthcare or clinical practice. This is in a simple way, but really it is more complicated and more advanced, and we need like days and days, and the one who is going for AI courses, they know that it takes few weeks just to go through this, but this is in a simple way. What about impact of AI today in our worlds? We know AI went through the medical application. The first thing is the radiology department, where there is an AI tools. They use it to detect small lesion, which the doctors, radiologists could not even see it. So it has been used, and we'll show you some data. Pathology, tissue biopsy, for example, cancer. So AI model has been used this to identify tumor cell, for example. What's happened? Hello? AI? We're off. Disconnected. Again, drug innovation, clinical trials. We have a lot of examples, and I will go through some example in neonatology. Electronic health records, data from NICU, So there is a lot of AI tools, devices has been implemented and started to be used in different occasions and in a different, yes. So like we said, it's radiology, pathology, EHR support, and administrative help too. So diagnosis of diseases, there is a lot of AI tool has been used for that. Medical imaging diagnosis, ultrasound, lung ultrasound, fetal ultrasound for diagnosis and supporting like detecting any abnormalities. Drug discovery, it takes years to have drug discovery studies and research. Now, by digital twinning, you can have it in a few months rather than few years for any new drugs. Personalized medicine has been used. Everybody know about robotic surgery, and some hospital, they have robotic surgery. Electronic health record. How many of you, your hospital use AI in electronic health record? Okay, so it is existing. And of course, the clinical trials. So there is, you can see, more than 100 AI devices approved by FDA. And from 2012, from 2 devices till now more than 1,000 of devices has been tested and has been really approved by FDA. So devices is available and it has been used for AI. What about neonatology? You can see this is the publication on AI. Adult, you can see, in adult, they started from 2001, less than maybe 200 publication. We reach now about 33,000 publication about AI tools. For neonate and pediatric, the number is small, but it's existing. So for a pediatric, there is about more than 1,400 publication about AI. For neonatology, we are reaching about 400 publication about AI and its use. Why in ICU it's a rich area? Because AI is hungry of data. And we have huge number of data in the NICU. We have heart rate monitors. You know, just imagine these heart rate, we come and see it in hour, but if you have a machine having all these in seconds, so each heart rate changes, and this was help in the tools where, for example, sepsis detection, neurological, EEG, huge data from our NICUs. Clinical exam, labs, delivery room information, physiological parameter, ventilator data. If you look to your ventilator, it's 24 hours, each minute, each second. They have these data, how much BIP, how much PEEP, how much FIA2, the changes, you know? So huge, huge data can be utilized in the ICU to use this algorithm to help in health care. So in simple way, like how we can AI applicable in neonatology through the machine learning, because I said data, we have huge data, imaging data, vital sign monitoring, and voices data, like in ICU noises, baby cries, for example, genome, exome, or deep learning through the imaging in the ICU, radiology, ultrasound, MRI, and all of these, even retinal images, and that will help in our prognosis, diagnosis, and possible treatment. And the same for clinical variable, other clinical variable. If you look the trends of AI in neonatology, so you will have like from predictive analysis, sepsis prediction, tools where like HEROES score. It's an AI tool where you can detect sepsis, chronic condition, BBD, BDA, neonatal mortality, extubation readiness, feedings, placental analysis, diagnostic imaging like ROP, chronic condition like X-rays, ultrasound, oxygen therapy, ROP screening if you are personalized care, like we want for a preterm baby or baby with, for example, HIE, neuroimaging, detection of seizure by utilizing EEG data, oxygen therapy, pain withdrawal, and of course, operational support or staffing, resources, clinical documentation, and others. This is some of AI techniques and application in monitoring and prediction, like early detection of sepsis in neonates, ventilator wean prediction. Can we wean this baby? We were talking yesterday about extubation failure and you know, BBD, the use of LISA, one of the research about some of the predictor for extubation and failure of non-invasive ventilation, prediction of length of stay in ICU and the outcome, detection of ROP, AAG, prediction weight gain, nutritional need, assist antibiotics for CHIP also, and of course, smart in ICU monitoring with AI integration tools. And maybe Prof. Joseph will talk about also NIC and probiotics and AI innovation in that. So let's start with perinatal medicine. So can we apply AL tool in perinatology or before delivery? The answer is yes. There is some risk assessment or genetic screening. So risk assessment like for detection of fetal heart anomalies, structural heart anomalies. So AI model with appropriate algorithm can improve diagnostic precision in detecting fetal heart or other abnormalities. And it will help also or supporting the physician diagnosis. It can predict also pregnancy complication. Like this is a Stanford Medical Center. They use an AI model to predict pregnancy complication. And there was an 80% accuracy with that AI model. AI also enhanced accuracy of, reducing the false positive screening in preeclampsia. Mount Sinai Hospital has using an AI tool to reduce, and they found it reduced false positive prediction, preeclampsia screening by 40%. So it's helpful. Genetic screening, can you do it like non-invasive screen for fetal abnormality, syndromes, congenital malformation through non-invasive fetal DNA analysis. We talk about sepsis, mortality. So an AI tool has been able to predict possibility of sepsis in the neonatal intensive care unit. And there was really accuracy about 95%. The same for risk of necrotizing enterocolitis in preterm infant. So logistic regression model and random forests achieve high performance in accuracy on, this is a study from Korea, and accuracy was about 0.93 for both models. This is two different models. And they found, a novel finding where ambient birth year temperature will be associated with necrotizing enterocolitis. And I think Prof. Joseph will have more talk about more tools. So application, can we use it for predict intestinal perforation? This is one of our nightmare to have a baby in the NICU with perforation or necrotizing enterocolitis. Can we use an AI tool to predict the fetal growth and how much we can improve, an intervention can be done to improve the developmental outcome, especially if we're talking about nutrition. BBD, again, another major issue. Can AI tools help in prediction of bronchopulmonary dysplasia? This is an interesting study about deep learning model and prediction BBD in a preterm infant using chest X-ray. And interestingly, they did a lung segmentation in about 1,500 images. And BBD prediction was as early as 24 hours. So the machine was able to predict babies who may develop BBD, and all these will support or get more insight about the use of AI in improving the diagnosis of bronchopulmonary dysplasia. Okay, I need to be faster, sorry. So AI achieved about 80% sensitivity and almost 90% specificity, and it was superior to the judgment of the clinical. Lung ultrasound, the same, visual assessment versus computer-assisted analysis and ultrasound evaluation for newborn with assessing his respiratory status. And what they found, this 600 ultrasound frame from 75 newborn with respiratory distress, and found significant linear correlation between the grayscale, the one who's doing ultrasound, they know the grayscale and the wide scale. So the gyre scale, machine learning analysis and blood gas index will be really correlated better than an radiologist, neonatologist doing a lung ultrasound. Retinopathy of prematurity use, it's like there is a significant AI tool has been tested to look for prediction of ROP, screening, and these tools really could be helpful, especially in area like Saudi Arabia, where we don't have ophthalmologists in all these periphery. So can this AI tool use to predict ROP, or to start screening baby at risk of ROP? The same for, this is another one looking for the accuracy between the traditional screening and AI-assisted screening. The same can be used for HIE. So AI model having improved neonatal care by early diagnosis and treatment. If you have an AI algorithm, and there is really deep learning machines yield high performance in prediction, even the 2 years neurodevelopmental outcome for baby with HIE. So can be used also for gestational age assessment through having, a segmented imaging of the babies, and with this neuronal network assessment can have an estimation about the gestational age. A lot of data can be used and utilized by artificial intelligent models, algorithm, and it can really predict model, and it can be help. What is the limitation, or what is the risk of large language model in medicine? Hallucination is one of the most important risks. You need to be really careful. You don't know what's, we are not a programmer, so we don't know what is, we have the input and the output. In between, really, we don't know. We need to look for the ethical background, safety. So still need to look at that. Error, it's really existing. So yes, ChatGPT and large language model is faster, is more accurate, but you need to be really very, very careful as end user. So can you use ChatGPT in medicine? How many of you used ChatGPT in medicine? By raising hand. Okay, so good numbers. So yes, you can use it. You can summarize research guidelines, draft educational material, administrative support, writing note, agenda, minutes, idea generation, and literature review. But you need to be very careful when you are making a medical diagnosis using AI. When you recommend the treatment, you need to be really, really careful, because who will be blamed if something went wrong? Ethically, you need to make sure providing patient-specific advice, and it's unsafe to enter identifiable patient data. So privacy is really important. Can be used in research. You see, if you go to PubMed, you find a lot of paper about AI use to generate paper, manuscript, peer review. But yes, it can be used, but we need to be very, very carefully at the start. It can help you in idea generation, literature review, methodology, writing, editing, and presentation, but not a full paper. And this is like a question at the end. Do you think AI will replace doctors? Yes? No. The answer is AI will never replace the doctors. But the doctor who knows or using AI, we may replace the doctor who don't, because it's really the future. So how we can support our integration between physician and the machine. So train clinician on interpreting AI data, build interface with that, explain AI reasoning, engage feedback loop between staff, we are the end user, physician, and the developer of the programs, or AI developer in your hospital. Keep human in the loop for the final decision making. Remember, a physician will come, I said, I'm not happy about the patient. This is not happening in the AI. And establish governance to track accountability of these AI tools or devices used in your care. Remember, AI is there. It's like technology progression. Remember, we have old computer at this, everybody, maybe the people who's like older, they have this computer. Currently, anyone have this type of computer? The answer is no. Now we have laptop, iPads, car. It's already vanishing, this type of car. Phones and mail. Anybody getting mail anymore? Paper mail? No. It's everyone getting his AI. So AI is the future, and maybe in the next few years, I'm not sure, 5, 10 years, 12 years, it will be hard to imagine us. Wow, there is a time when healthcare operation without support of AI. And Saudi Arabia is encouraging AI, and it's one of the top countries in that. And this is مبادرة مليون سعودي للذكاء الصناعي. It's a free for all healthcare provider, for all population in Saudi Arabia to be aware about the basics of AI. And here I would like to end my presentation, and thank you very much.
Thank you, Dr. Jabara, for your talk and interesting fact about AI. AI is coming. I like the last slide. We should be ready. There is no way, and it's similar to any other technology, and we should be ready how to better utilize it in our field. طبعا, even in our life, I think AI will be a major cornerstone, similar to the internet in our life. Thank you, Dr. Jabara. Without delay, I will introduce our second speaker, Dr. Talal Al-Tamimi. Dr. Talal Al-Tamimi is a consultant neonatologist at Imam Abdurrahman Al-Faisal University and King Fahd University Hospital in Eastern Province. He is specializing in neonatal hemodynamics and POCUS. He's the lead of this service, and his research interest in cardiac function, including congenital diaphragmatic hernia and prediction of pulmonary hemorrhage and ultrasound-guided vascular access. Because of this, Dr. Tamimi will be talking about innovation in vascular access and reducing venous depletion today. Dr. Talal also is the head of the scientific committee for the 23rd Neonatology Conference, and we appreciate his effort and the committee member who arranged this exciting program. Dr. Talal, you have 30 minutes, and we'll be reminding you once 5 minutes left. Please.
Thank you for the introduction, Dr. Imad. It's very hard to match Dr. Jabara's presentation. Try to do my best. Let's just wait for the slides to show up. Great. So I'll be talking about innovations in vascular access and reducing venous depletion. It's a topic I'm very passionate about, and I feel it's a topic that is underappreciated. We kind of don't really think about vascular access and if we have a baby and the nurse just got an IV, we're done. We don't really have any continuity of care in regards to vascular access, and we end up with babies that are older, having BBD, staying for the unit for a long period of time, and they have central occlusion. And this is a big issue. And the problem is, us as neonatologists, we're not very well versed with central access, inserting an internal jugular or femoral. The amount of people I've seen, at least in the local region, that are well trained for central access is limited. And we kind of defer always to interventional radiology or the pediatric intensive care. So there is a gap. I have nothing to disclose, and this will be a QR code for a vote during this presentation. So if you can kindly scan it and keep it for your reference until we get to the vote. Okay, I hope everybody got that. Great. Okay, so I'll be talking about the terminology. Be talking about the optimal site of insertion, also optimal dwell time, catheter selections, innovations in fixations that we're really actually using right now. It's not something in a textbook or we're still reading about. It's something available in the local market. And monitoring of extravasation, introducer selection, and some practical tips for insertion for babies less than 750 grams. So I always get into this mistake as well, which is calling this venous axis the PIC, calling the ECC a PIC. So a PIC is a misnomer, it shouldn't be used. After 2018, the World Congress of Vascular Access actually defined what is a PIC and what is an ECC. Any line that is considered to be less than 3 French is not considered a PIC. It is considered an epicutaneocaval catheter. And even if you look at the manufacturer, the well-known manufacturer here in Saudi Arabia, they clearly write it on the box. This is an epicutaneocaval catheter. Now, the reason for distinguishing those two catheters from each other is that they have different characteristics, they have different uses. And so lines that are above 3 French, they're considered to be PICs. They are power injectable. You can give contrast through it. You are able to give blood products, and you are able also to withdraw blood. And the rates of collapse is very different than those that are smaller than that, the 2 and 1 French. Now, the ECCs are the smaller ones. They're more superficial. They're the 1 and 2. And this is the one that we're mostly using in the NICU. So they're quite different. Okay, so now the question is, where do you prefer to insert your ECC? Upper limb, lower limb, scalp, wherever I can find a vein. We always get very different answers everywhere, so I'm interested to see the audience today. What will they answer? Okay. I'm sure some actually put in the lower limb. Oh, we're seeing a lot of people. Okay, so the numbers are changing right now, but I can see most are actually going to the upper limb, which is very interesting. Okay. So let's look at this meta-analysis, and I think this is the one that actually answers most of our important questions. What are the complications and what are the chances of non-elective removal of those lines based on where is it inserted? So this one looks at all non-elective removal of lines, regardless of what the cause is. And we can see it actually favors the lower limbs. So lower limbs, the chances of non-elective removal is actually lower. But if you can look at this, which is catheter-related infection and phlebitis, it actually favors the upper limb. And this is probably because of physics. You have the catheter in the lower limb, and the baby is moving their leg up and down, and the catheter is actually moving inside the lumen of the vessel and irritating the intima. Probably that is contributing to phlebitis. Also, there are reports in adults, the baby, when they were young and they had lines in the lower limb, they had higher chances of varicose vein and higher chances of DVT. So probably some of our interventions in the neonatal period actually have implications to those babies when they become older. Now, if we look at thrombosis, it actually favors the upper limb as well. Same concept. I think it's probably due to the repeated phlebitis and the repeated trauma, which makes it a very good environment for thrombosis to happen. So again, you have to risk-benefit. You have to weigh in things. Where are you going to put it? You're going to risk the chances of thrombosis and infection. You're going to risk more malposition in the upper limb. You have more malposition. But I think at the end of the day, we're going to insert it wherever we have an access. You're not going to say, I have a good line in the lower limb, but I'm not going to go there because the evidence says I can't. But at least recognizing that having a line in a certain location actually increases the chances of a certain complication. So another question for the audience, how long do you typically keep your ECC if it's still required? And again, this is a very controversial question because I've also been getting different answers each time. Okay, so you got less than 2 weeks. You got no specific duration, less than 1 week, less than 4 weeks. You can see it's almost probably equal. Again, Recommendations versus real-life data or real-life scenarios. If you look at the manufacturer, they also mentioned that you should keep the line for 28 days, not more than that. But in reality, I'm sure everybody probably keeps it a little bit more, because you're not going to insert a new device and risk, infection, trauma, all of that, just because the manufacturer says that you have to remove it within 28 days. The other thing is, if you look at the data, at least in the pediatric and adult data, the longest dwelling PICC line was actually probably 6 years. And it was in a patient in MD Anderson. I'm not saying that our neonates will stay for 6 years, but it tells you really that good care and monitoring for complications for those lines is adequate, and you can probably use it with caution. And I think one of the important papers that talks about the optimal dwell time is this paper in 2013 in pediatrics. So it looked at PICC, and this is before the time there was a distinction between the terminology of ECC and PICC. And what you can see here, the adjusted incidence ratio for CLABSI actually went to 3-folds during the second week up to the third week. So we can see that. And then after the third week, it actually goes down to 2. So it tells you that after 2 weeks, up to 3 weeks, this is the highest chance of infection. And again, depends on your unit and how fast you're feeding your babies. Maybe if you have an ECC and you have an appropriate, I wouldn't say fast, but faster feeding protocol, you may not actually need an ECC for more than 2 weeks, and therefore you will mitigate the risk of infection. One of the other things, of course, I can't cover all of the things that Dr. Saif yesterday mentioned in the CLABSI presentation and prevention, so many interventions, but one more additional intervention that we've been doing for the past 6 months is using cyanoacrylate glue. It's a fixation device. Rather than having steri-strips or whatever it is, adhesive that you're putting on the catheter hub, we're using a small tiny packet of glue, cyanoacrylate. You keep it on the insertion site and you keep it on the hub. It is available. There are so many products out in the market, and today in the vascular access workshop we will demonstrate this product and how to use it exactly. Comes in small tiny sterile packets. And interesting enough, it has been used in the region as well. And they have a nice quality improvement project in Qatar where they actually used this, and they showed significant reduction in CLABSI. Now, the physiological reason why probably it reduces CLABSI is that it reduces the dislodgement rate of the catheter, and it doesn't make it go in and out, and that's probably what drives bacteria inside the bloodstream. The other thing is it itself, cyanoacrylate, has a antibacterial and antifungal property. And also it kind of keeps a good seal and good cover that prevents moisture and fluid from going in. Another reason also to think about, and it is a big factor in non-elective removal of ECCs, is where the tip lies. So we know the bigger the vessel, the better, but probably not all vessels are the same. The gold standard is just having the tip at the SVC and RA junction. Sometimes it's really difficult to ascertain if it's really there, regardless if you're doing echo or you're doing X-ray and using the tracheobronchial angle, you're using T2, whatever method that you're using. You can see here what is quite interesting, that if you have a centrally inserted line and it is still in the femoral vessel, the odds of removal is 10-fold. So having it in the femoral is not really a good idea if it doesn't cross the midline. Also, if you have an ECC and it has been inserted in the lower limbs, but the tip is still in the femoral that haven't went to the IVC, the chances of non-elective removal is high. Another issue as well is the cephalic vein. Having it in the cephalic vein, although it is very nice and easy to insert in the distal part of the forearm, having it still in the arm before it crosses the shoulder is actually associated with higher odds of non-elective removal. So this is something to bear in mind. Okay, so this is the million-dollar question: is do you use ultrasound for your vascular access or not? Yes or no, and is it central or peripheral? Okay, it's a bit slow. Okay, I don't think it's going to work now, but yeah, it's coming. Okay, great. So no, that's the majority of the answers that we get most of the time, is that we probably don't use it in the NICU. And you're not alone. Even in centers or countries where they're using ultrasound more and more, they're still, in the NICU, we're still behind in use of the ultrasound. Interesting survey that was done in Europe, this is in Spain, when they asked people, do you think that training fellows for ultrasound is important? Around 40% only said yes. And if they said, and they asked them, do you think it's useful in daily practice? Around 50% only, yes. So still, we are still far behind, having only 50% of healthcare providers in the NICU still believing that ultrasound is not useful, actually goes against guidelines. So my aim is to sell the idea of vascular access using ultrasound. It's really a game changer. We've been using it since 2020, and it has been absolutely amazing. So this study was done in Japan, where a group of anesthesiologists were putting radial lines in infants in the OR, and they were using palpation method versus the ultrasound. And you can see the cannulation time was much shorter, and the first attempt success was much higher, around 40%. But what is interesting is the total success rate, approaching 100% in ultrasound in comparison to around only 60% in the palpation group. So think about a procedure. If I tell you that your success rate in intubation is around 60%, is that okay? But of course it's not. But why is it okay if we're going to insert a line? Why are we accepting a 40% chances? It doesn't make sense. Same thing was done in China. They compared ultrasound insertion versus in the saphenous vein versus just the conventional method. And the total success rate was a 92% versus 74% in the conventional method. I can go on and on about the evidence that is out there. And, but even if you look at smaller babies, this study was done on babies less than 1.5, which is our population that we're worried about. We can see that the success rate in this study that done in Europe is around 100% in those babies with median gestational age of around 29 weeks. Also, this study in Japan looks at where is the best site for insertion of a PIV in babies, and they found out that the cephalic, although it is there's a high likelihood of kinking and it doesn't go to a central position, it is actually one of the best sites for insertion and success. And this actually goes with our data. We're going to publish this, me and my colleague, Dr. Amr Khalil and Abdel Shqaiman, since 2020 up until now, around 311. And you can see that most of our cases are actually in the upper limb, and in the upper limb, most of them were actually in the cephalic forearm. So it is one of the best sites for insertion. Nurses usually don't see that because it requires ultrasounds. It's a little bit higher up in the wrist. It's not usually seen. Something also very interesting that although around 50% still don't use it, if you look at the international guidelines, this is the European ESPNIC guidelines, what you can see here is POCUS-guided technique should be used for internal jugular, and it is helpful for peripherally inserted central catheter. And you'd be surprised at how many people until now, they still use the blind technique that they learned a long time ago for insertion of an internal jugular. And that's very, very dangerous, and I've seen it being done so many times. The reason behind this is, although even we're using landmark techniques for identifying where is the vein and where is the artery, this study that was done in Colombia looks at the anatomic variation of the position of the internal jugular and the carotid. And you can see it can be next to it, medial, or lateral, it can be above it or below it. So landmark techniques may not be the ideal way for assessing the vein. Also, this guidelines has been published a long time ago, so since 2012, international guidelines for vascular access. And this is an interesting point here. They mentioned blind, deep antecubital fossa puncture should disappear. How many of us actually were trying to insert an ECC in the antecubital fossa and we missed the first attempt and the second attempt, and we were just trying to fish for a vein? I think I've personally done it, and I've seen many trainees also doing that. So what are we risking here? We're risking injury of the brachial artery. We're risking also injury to the median vein. Is that an injury of the median vein actually can be permanent? And we're not following any of those. So I think it's very dangerous as well. Also, if you look at this international evidence-based recommendation, where they adapted this from the INS, the Infusion Nurses Society, they recommend that to avoid the risk of venous thrombosis, they recommend that the external catheter does not exceed 1/3 of the internal diameter of a vessel. So an easy way to remember it, that the internal diameter in millimeters should equal the French size of the catheter. So for example, if you have a 2 French line, the minimum vessel size that you can insert the line in is 2 millimeters. Now the problem is, are we actually measuring? And this is another issue. An interesting and a very well-known researcher in Italy, Giovanni Barone, actually had the same question. So he said, let's measure all of the vessels in babies and stratify them based on birth weight, and let's see how big are the vessels. And you can see here, we're focusing on the brachial and the basilic veins. And look at those numbers, very interesting. From babies 2.5 up to 3 kg, it's around 1.5, 1.6, 1.3. So none of them actually reaching 2. And this is a problem that we are mostly using the manufacturer recommendation, which is to put a size 2 French in babies less than 2 kg. But by doing that, we're not really following the INS guidelines. So this takes us back to a very important question. Should we even keep size 2 French lines in our units? Probably not. Yes. So this is our local policy in our hospital. Also, it is adapted from the Italian guidelines. I think they're one of the pioneers in neonatal vascular access. If we have a line that we need it for more than 7 days and the baby is unstable, we prefer to put a centrally inserted catheter. The reason behind this is if the baby is unstable enough, it will probably require blood products, and you just can't keep poking the baby again and again to put a peripheral line to give a blood products. And also you need to extract a lot of blood, so having an internal jugular might be a safer option. And also, if we need the line for more than 14 days, we think about inserting a centrally inserted catheter. The reason behind this is it actually carries less risk of CLAPSI in comparison to ECC. And I think this was something new to us. We learned this recently. We always thought that having an ECC actually carries a lower risk of infection. It's actually the other way around. Having an internal jugular, although looks unappealing in comparison to an ECC and feels that you're not doing service to the baby, by having a big line there, it actually has lower risk of infection. There is another catheter that I see a lot of people ask about, which is the double lumen ECC. And I think it doesn't really have any place in our guidelines or in our clinical practice. The problem with double lumen ECC is that it is big, it is a 2 French, and it is used if you have infusions that are not compatible. So, for example, you're giving insulin or you're giving bicarb for a baby. But if the baby is that sick and requires that amount of support, probably he should have a centrally inserted catheter, not a double lumen. So again, another important dilemma that we have, sometimes that we have a patient that requires antibiotics, but it's really well, and we really don't want to put an ECC. And we think that having a peripheral line is too little. We keep asking the nurses to insert it multiple times. Multiple insertions going to lead to venous depletion. The nurse is going to be overloaded. So in the past 3 months, we started to introduce new type of catheter. So it's called the extended dwell catheter. They call it many things: extended dwell catheter, long peripheral lines, many terminologies. And just to highlight, those are not midlines. Midlines, their tip should lie in a central big vessel. Many articles around there about their use in the neonatal intensive care unit. It's quite safe. Multiple products are available, and we're going to demonstrate how to use those in the afternoon. Generally speaking, it is a peripheral inserted catheter that is 50% longer than the usual ones that we're using. And what's very useful about it is that it can stay for 28 days, but realistically, it stays for 14 days, 10 to 14 days before elective removal happens. And also, you can give blood products, which is safe because it is shorter. It is around 4 to 6 centimeters only. The pressure needed in the pump is not really high to affect the RBCs and the platelets. And also, you can give peripheral TPN just like a peripheral line. If you can play the video, please, here. So another device that we've used for the past 2 months now, because last year we had multiple incidents actually with extravasation of the line. So we reviewed the policy for nursing assessment of the line, and also introduced this new device, which actually is a near-infrared spectrography monitor that is kept on the insertion site, and it measures any changes in the nears and alerts for infiltration before clinical signs occurs. Doesn't replace routine nursing assessment, but it is something that we are starting to use only in high-risk patients. For example, a patient that is currently on IV calcium or is having an inotrope using an IV or on peripheral TPN. That patient we will attach it on. Also, they are using it in Qatar, and this shows actually sensitivity of 93% to pick up infiltration before clinical signs happens. Okay. There are gaps in the neonatal market, especially for the introducers, and I think this is
5 minutes.
5 minutes, sure. There is gaps in the local introducer markets, and I just want to share this one. And I think we are probably all very much familiar with this introducer used in our lines. So this was first manufactured in 1976. And this is the original introducer for the ECCs. And it's still being used until now. This is a 19-gauge introducer. Now, the newer ones that we're trying to see right now, although it is not registered in the NIPCO, is the 20-gauge. If you look at the vessel diameter for the introducer, you have the 19-gauge. You need a vessel that is 1.3. And you can see that even the bigger ones, sometimes they don't reach 1.3, especially if you have somebody 1.5 to 2 kilograms, they will not reach that weight. So having this introducer is not something very useful to our patients. Now, the other lines that are still unfortunately not available and not registered here in Saudi Arabia, which is the ones using the modified cell decanter technique, whereas the introducers is very small, 24 to 26, and is reported to have very high rates of success. The other product that is unfortunately not available, but is available in North America, which is a really tiny one introducer, a peel-away sheet, 26 gauge. And I think that final product is a game changer, and I'm still trying to find out why we can't have it here in Saudi Arabia. So practical tips for insertion of the ECC. I think I just want to point out here that during the insertion, one of the most important things, other than where you're keeping the patients, where you're keeping the machine and having the right setup, is having heat, And I think this is something very much overlooked, even if you were without using ultrasound. So when we were inserting in difficult access team, during the fellowship, we would go to the pediatric floor and insert there. And we would scan babies when they were still at the mom's lap, and we would not see any veins. Once we take the baby out, when we take the baby to the treatment room, put them under the radiant warmer, we suddenly see that the veins are huge. So there is a big effect of heat that we kind of overlook sometimes. So another tip is also, this is for people that don't have ultrasound guided insertion, don't have somebody expert, and they need help from interventional radiology. Avoid transportation. Ask them to come rather than you sending the baby there. There is so many risks about sending the baby there, especially hypothermia, increased mortality, unplanned extubation, and I think the audience knows all of this. Avoid benzodiazepines when you're trying to sedate those babies. Try to use appropriate sedation for them, especially if they are having difficult access. Pain and movement are one of the things that actually make insertion quite difficult. We're starting to use in our protocol, Presitex prior to insertion for all difficult access babies. Get an ultrasound machine and get the right one, and check the specs and make sure that you have a high frequency linear probe. There are so many in the market that are even above 15. You have 18, 20, and 22. Get them. They really do a good job. So I'll just share. Can you play the video, please? So this is just a video of the insertion. Can you? So you can see the insertion here, that what we're trying to see, this is with a 22 megahertz transducer, and we're trying to insert the catheter or the introducer along the way in the vessel, and we're trying to get enough purchase in the vessel. It's not that we're trying to see the backflash and we're removing it. We're going deeper and deeper and try to secure as much of the introducer inside before we thread the catheter. And you can see here, it's very clear. You can see that the vessel is quite dilated with enough sedation and with enough heat. Perform a pre-scan before insertion. Have a plan before inserting. Try to find out where is the optimal site, where is the bifurcations, and what are the valves and where to avoid. And also scan a little bit high to see if there is any thrombosis that happened because of previous insertion. It will make it very difficult for the line to go up. So scan above. So difficult access team was a dream during my training, and I'm very happy to see that the team is doing really well. My colleague Jack Brar in the PICU in Children's Hospital, London, Ontario, developed this team where I was training the nurse practitioners in the ICU, and he was taking care of the pediatrics. And we got a couple of nurses trained to do this, and it was really a game changer. Again, there are many opportunities for training. I'm using this platform to really advertise for an elective that we have. Unfortunately, I think workshops will give you an introduction to what to expect and how to do it, but I think mentorship and having somebody to hold your hand while you're doing it and stay with you for a whole month is important. So we're having an elective for hemodynamics and point of care ultrasound and vascular access, and here is one of our visiting fellows that comes in and learns how to do the lines. So please reach out if you're interested. So take-home messages here is ultrasound guided access is the standard of care for central access, and it is becoming the standard care for the peripheral access. And sometimes ECC, although appealing, may not be your ideal device for your baby. Thank you very much.
Thank you, Dr. Talal, for first being on time, and second for the interesting talk and the lectures. I think also another growing field that soon I will be seeing major guidelines shifted to stop doing blind insertions, as you mentioned, and I think more to come, inshallah, in the open session for discussions from the audience. Our next speaker is Dr. Ali Al-Mudir. Dr. Ali Al-Mudir is an assistant professor and neonatologist at King Saud University Medical City, Riyadh. He is also the clinical lead in the Ministry of Health for Neonatology, and NICU led for Saudi Virtual Hospital. Dr. Ali Mudir will be talking about telehealth and virtual hospital, Saudi experience perspective. And Dr. Ali, welcome on stage. You have also 30 minutes. You will be reminded once finished, 5 minutes left. Thank you.
Assalamu alaikum. Good morning, everyone. Thanks, Dr. Imad, and thanks for the scientific committee and the SNS for this invite. So in next few minutes, we will go together to see the experience and journey of Saudi Arabia in telemedicine in the NICU. So we'll talk, in our talk, we'll have some slides about why we need like the telemedicine or the virtual services, and what's the model we are using now, and what's the outcome beside the challenges we face in the daily practice and when we implement this service in the virtual hospital at the level of Ministry of Health, and couple of examples we captured during our experience. So why in ICU health? So all of us, we know that, especially in Saudi Arabia, the geographic distribution is very wide, and the NICU needs everywhere is expanding. And always we need to support our colleagues either with physical services or telemedicine when it's available. It's one of our momentum since we start to have the vision of 2030. And the virtual hospital at different level in MOH started, so we try as neonatology services to take advantage and take and utilize those services available. And when you work in the NICU, especially in level 3 in ICU, you start to have a need for subspecialty like cardiology, genetic, pediatric surgery, and different other, which is not available everywhere and every day. So 3 years back, May 2022, we start to request to have these services available in the Saudi Virtual Hospital. And the trigger that time was when we assess our NICU level 3s, always we assess different KPIs. One of them is the occupancy rate. And the trigger here was for one of the largest level 3 in ICU, which we look at the occupancy rate, and it was interesting seeing that it's almost above 100 per year for more than 2 years. And that's in ICU, was the only level 3 in ICU in almost like catchment area more than 1 million. So that time we decided to jump in with our colleagues in the virtual hospital at the level of MOH, and we try to implement the services and see what's happening in the future. So the model which we are using nowadays, and you can see it everywhere, that we have video, audio services, consult. So you have pediatrician or neonatologist bedside, and you have neonatologists and full team like nurses, RT in the virtual hospital. So we start like we have the tele-rounding and care plan review together every day. And during the review or the round, you can review everything, like the data, the events happening overnight, if you have chest X-ray or head ultrasound, if you need other services like cardiology or echo, so other colleagues or departments, they can help you on that. So also we triage the cases day by day. What's the cases need to be referred to the different services or different centers. And again, if we need to interpret something else, even if we need to counsel the families during the round. So this is some example of our daily practice, what we are doing. So you can see, you can check and baby on cooling machine, amplitude EEG. You can help in interpreting that one. And again, you can review the X-ray with them and give them the guidance. So again, so the use of this one in the settings, as we mentioned, it guides our colleagues to diagnosis, to intervention, and again, sometimes even the decision of discharge. So we can also look at their ventilation parameters and how is the nutrition status, and we can help them in some of the consultation. So what's the benefit expected from our experience? Exactly like especially the subspecialty in genetic and cardiology. We have also the team tele-cardiology and telegenetic working with us beside the beside the critical cases. And we have also helped our colleagues to have more adherence to some of the bundles, especially the golden hour. And we, with the time, we built some of our own like protocols, especially like the early onset sepsis assessment. So we feel that all of this can help in reducing the length of stay, some preventing some of the transfer. And again, with the time, we feel that we enhance the trust of our colleagues in their competency and how they are doing in their side. And we utilize the tele really round very well in counseling, big decision with the families, person counseling, and different things. So that is not without challenges. So if you come and visit us in our virtual hospital, or you go with us through this journey, you can see a lot of daily challenges. So sometimes we have connectivity issues because we use the signal, the usual signal to work our carts. So the workflow, sometimes it's not easy to go and do only the rounds. The people sometimes very busy in the ground, they have emergency to do something with that. And again, with the time, we found that we need really to have some license credential for the people working in the virtual and in the ground. The change management is another challenge for the people in the ground. So we try our best for the team who is working with us to try to retain them for longer time, so we decrease this challenge. So what we usually expect and we follow with our colleagues in the locations, so we look at specific KPIs and we look about the response time, and I will show you how many beds we are covering today, so you can see how much the amount of babies we are seeing per day or per shift. So with the time, we recruit more location and more bids. So that's affects sometimes our time giving the consult. But with the time, we learn how to make this response better and how we utilize the service everywhere and how we calculate consult per bid today. So this is our main dashboard. 3 years now, we cross 1 million consults since we start. And you can see this is the dynamic dashboard in our hospital. Day by day, we can see how much the beds occupancy, how many babies we see per day, how many baby went home, how is the occupancy rate, which was one of our trigger we start with. So again, we also look at the infrastructure, how we build it with our colleagues, how we do the consent with the locations to start with, and how we try to find a backup solution if we have a connection issues. So this is the workflow. So as we mentioned, we receive a lot of requests from different regions. They like to join these services. So we build a workflow for everyone if we wanna, they request to join. So we look at the trigger, why they want to join the services, how is the connection like speed, and how is the structure huddle, and is it possible to have shared solution between us? And then we go to have an agreement letter between us and the location. What is the agreement? Is they just need consult, or we run the locations by ourselves totally? So again, this is included in the letters, how we governance and how the policy consideration for the locations and what's the vendor we are using. So this is the journey. We usually have it. So it takes us some time, up to 9 months, to start the service and escalate everything. So usually we design the location or design the KPIs, everything. Then we start piloting with the team. And then with the time, we see how the integration is happening between us. Then sometime we go per year 1 to 2 sites only, then we escalate. So till today, we are live with almost 8 locations and around 180 beds, almost, let us say, around 120 babies we are seeing per day. So this is just an example, and you can interact for those cases which we captured. We captured a lot of interesting cases during the day. And so we have, like, let us say, 2 consultants per day doing like the round with them. And we have a steering committee, almost 10 consultants. So when we have interesting or difficult case, we just like throw it in that group and we discuss it and we try to find a solution for that. So this is level 3 in ICU, which the capacity almost 25 beds in one of the periphery regions. And the trigger was a full-term baby with respiratory distress, difficult to ventilate. So the one who was working on the surface that day, so he started his round, he did his video assessment, and he have some ventilation adjustment and chest x-ray. And this is the baby x-ray. So any proposed action for such a baby? Full-term baby with RDS desaturation with that x-ray. Fellows, okay, intubate. So it looks like HMD. So intubated after this X-ray. Kinked UVC. So he was intubated, received 1 dose of surfactant, and then the advice was to review the X-ray, and some of the colleagues, they suggest it looks like he's a full-term baby. Maybe it's cardiac disease underlying. So the echo done only ASD level secundum, just left to right shunt. So this is the follow-up X-ray after 4 hours. Okay, interesting. So this is showing like right side pleural effusion. So we confirm it by chest ultrasound. Everyone was showing that ultrasound live. So because it's in a periphery, nobody is expert in like lung ultrasound, and it's confirmed. Then they insert chest tube, and with the camera we look to the baby hole, so it was clear that there is lower limb edema. So this is the pleural fluid aspirate. And baby stay like almost 40 days, intubated for 10 days, and baby was started on monogene and octreotide, and we prevent like the transfer of this baby, so he was kept in that hospital. We counseled the family about the management and the time we need to escalate, and we like successfully managed this baby. And this was on the last International Prematurity Day. We just asked the family to come and participate with us virtually. So the second case, this is level 2. We have 5 location level 3 working with, and 2 level 2, 15 beds. Another region in the south, so full-term baby with persistent cyanosis, as they like escalate the call or consult to us. And we start to do the video assessment overnight, and they share it with us in the group. Any thoughts? So baby on 100 FI2 through nasal cannula, and the saturation is around only 80%. So this is the blood gas, was done after the video consult. So echo was normal, X-ray was normal, nothing there. Oxygen was not beyond 80%. So if you look back in deep for the blood gas, so we see that the methemoglobin in the blood gas, showing that it's be above the reportable range. And that's really from the first consult colleagues, they just saw the blood gas, and this was the thing there. So this is the baby after administering methylene blue. So dramatically he changed. This is the video after like 12 hours. So the baby improved after administering methylene blue and diagnosed methemoglobinemia. Then we refer him to the subspecialty people, and that was one of the things we avoid transfer on that time. He was almost like 2,000 kilometers from Riyadh that night. So what we are doing also, so we try to train nowadays our colleagues in the locations, how they utilize the surface, how they start the trigger for us. And we build a competency for the people to know how to even share the alert for us. We develop also the checklist for the physician, nurses, and RT. And we have a workshop how to have to dial the people. And nowadays we are covering 24/7. So physically the consultant will stay the morning shift. Overnight he will cover by landline or by the video consult if they need him. So we have like weekly meetings. We huddle with the locations, and we have a team monthly meetings and refresher for some of the old locations. So all of this is sometime not without risk. So as we mentioned, on some challenges also. So we try our best to improve and to recognize the people who's really improving in their services, in their KPIs. And you can see easily how, as we mentioned, like over 3 years experience, we have 5 level 3 in ICU joined, 3 level 2, and we have 185 beds. This is our teams, and easily you can see how the location is having their admission over time. Najran is leading because it's the only in ICU level 3 in the region. So what's the future? Dr. Jubara, she talked about AI. So we have a new model. We are trying to implement 2026 AI driven for resuscitation. So we fix a solution or video audio in some of the delivery rooms, and we have a physician in the virtual hospital to lead the resuscitation when they are needing. We are starting by the morning time. And nowadays we have a new solution who integrated with HAR, so we can have all the documentation seen by the physician. And again, we are planning to have some of the papers coming from this experience. So again, we are trying to have specific protocols and policy specific targeted for this virtual locations. And we are trying to have specific programs and reports to be published. So takeaway messages. I think the NICU telemedicine is, again, it's not replacing what we are doing in the day, but it's one of the facility which we can utilize it very well, especially in the area we don't have the expertise available in the locations. And we are expanding, heading to around 300 beds location in the first quarter 2026. And again, building the knowledge and having clear workflow, clear governance and metrics, that's one of the critical for success. So we start small, we measure everything, and then we scale to adopt all the need. Thank you very much.
Thank you, Dr. Ali, for this informative session. If I might ask the speaker to join the stage for 5 to 7 minute discussion, please. So it's time for Q&A. If any question to the guest speaker, please call for the microphone.
Thank you, Dr. Jawara, for the fantastic presentation on AI. I just have a feeling that so nowadays we are writing reference letters, you know, residents, fellows, medical students, everybody. And so the reference letters I'm reading, they are all AI written now. And they are like, wow, everybody is excellent. There is no bad individual because AI is being used. And I feel that AI is taking the soul of our writing. Khalas, we have no personality now. Everybody is using AI to write a reference letter. You just tell the AI what this individual has, like in terms of skills. He will write a 2-page reference letter that is مش عارف أوصفه كيف يعني بس very strong. So I feel that we need to be genuine. The AI takes the genuity off. And just like everybody is similar. The writing skills are strong. The individual is excellent. There is no bad doctors anymore. Khalas, AI is doing the job for us. I just feel that when I write a reference letter, I start with this letter is not written by AI. It's written by myself. So I just need to highlight the importance of just be genuine, be yourself. You can use AI in summarizing research, you can use AI in correcting some mistakes, but just like drafting everything using AI is just makes us lazy and makes us sometimes like fake. Thank you.
Yeah, thank you very much. I do agree, but again, AI is a tool. So for a busy neonatologist, which I have like a lot of things to do, but it will not take our role. It's like AI is supporting our role in many things, including, for example, I tell you, yes, AI generated, for example, recommendation letter. Yeah, I do it myself. But I look carefully. You will not really do it through AI and just specify, input what you need to write. But it will really make it easy because in a few seconds, less than a minute, you will help. AI tools has been really discussed in education, how you can utilize it in education, in teaching, in university. So it's a tool and زي ما بيقولوا سلاح ذو حدين. So it can help and it can be abused. So that's why our rule as a human, because even in the exam and in the study in school, people really unhappy about utilization of AI by children. We are mature now, but a growing children at school using AI, we will be maybe in the future have a problem because their decision and their thinking it will be really impacted.
Allow me just a quick comment. I totally agree. When you ask the question, does the AI will replace the physician? It will never. Because physicians, they are not just prescribing, they are not just intubating, they are not just putting lines, talking to the family, counseling the family. It will never happen by AI. And family will never trust some computer come and talk to them. They want human being, they want feeling. They want somebody passionate about what they are feeling, sympathizing, empathizing with them. I agree, you said that a physician, knowing AI is a good physician sometimes. We need someone to know AI, let's agree, but it will never replace.
Yeah, totally agree. And the problem now with the patient and parent using AI for medical knowledge. And this is really, it's increasing. We see a lot of patients coming to our clinics and really discussing, because you said, I review through the ChatGPT and I'm not happy about this, you know? So even these tools in used by non-professional, you know, like public, they are not the doctors, but they use AI for their treatment, their decision making, which is really need to be controlled.
I would like to thank the speaker. Actually, really very interesting session. I will take the chance of the presence of Dr. Ali Mudir and Dr. Talal Tamimi. When we take a call for Safe Life, sometimes we have tertiary care center for NICU, like level 3, but they have problem with IV access. They need to transfer the baby for difficulty to insert the IV access, central line and others. Everybody there, anesthesia, pediatric surgery and other, they don't know how to do it. I have a suggestion as a project. It's a few hospitals that maybe a team will go there, an ultrasound will be available, and we train them, 1 or 2 in the same center, to have this IV access, instead of transferring very small baby, 3 hours, 4 hours sometimes, to another center, just for IV access. And some of them, they don't have any line. Imagine what's going to happen during these 4 hours. Thank you.
Yeah, that's a very valid point, and we've encountered this before, babies coming in just for IV access. And I wouldn't say it's a problem that we have here only locally. We've had this also outside during training. And it is a real challenge. I'm going to leave the collaboration bit for Dr. Ali to answer for. But in regards to training, ultrasound training is there, but it won't be replacing emergency access that people think are still not trained to do. We've seen some units where still they haven't really incorporated intraosseous, although it is in the NRP as well. We've seen also pediatric intensive care units, still they don't stock it. And I think that's also equally dangerous. But I think the bit of training and for ultrasound-guided vascular access is very valid, Dr. Saad.
Yeah, thank you, Prof. I think I agree with you. So at the level of Ministry of Health, we have 34 locations level 3 distributed in the whole regions. And 2 years back, we have a lot of same complication and sometimes even complication from trials of putting IV lines. And we have very major incidents with that. So we built groups for PIC line or ACC, so Talal will not be upset from that. And we start with the regions with less experience or nobody available. Now again, sometimes it's very challenging, as you mentioned, if I take like north borders. So the level 3 in ICU in Arar, and the next like hospital is around 300 kilometers. So I think this is open for all of us for collaboration. Probably Talal is pioneer in that one. We'll try to see how we can help our colleagues in the location in the near future, inshallah.
Thank you for all speakers. And my first point to Dr. Jubara, I about to mention, and she talked about it, that the AI can be used for non-professionals. And now the hospital, all hospitals are transparent with the family. They can access the result investigation, and there is even AI explanation. And they will come for you next day. You find 3, 4 families you want to counsel them. One of them came at 4 a.m. that the ChatGPT, they found the blood sugar 160 and replied that your baby is diabetic. So you found them waiting for you, and what is the answer? So really it is a big problem. وهي سلاح ذو حدين مثل ما تفضلتي. It is really a big and complicated problem. My second comment and question to Dr. Ali Mudir regarding the telehealth and helping all people in peripheries. The only thing I want to ask about the medical legal issues and documentation regarding when you are counseling and doing telehealth and you have a difficult and complicated case.
AI.
And everybody had the same. I think all our generation, they are ChatGPT in love with. So they are in love with ChatGPT. So really when the parent come to me, I told them, if your car, something wrong with that, you will go to ChatGPT and fix it? Do you know the problem? He said, no, I'll go to mechanic. He said the same. This is the specialties. So whatever in the ChatGPT, you cannot interpret. And there is a lot of, wrong information in the ChatGPT. You will never know it unless you ask for the expert. Okay? But still, you will face a lot of these, patients coming to us. Even they are, questioning our management. Why you are doing this? Why you didn't do this? Because I read there is an alternative treatment. Why you didn't do it? So I think mass education need to be done for at the public level, and it's really it's happening.
So the second part, Dr. Ahmed, with the time we overcome this conflict. So in virtual hospital, we have two parts of agreement. When we sign the agreement with the location. So the famous agreement is consult. So we are not the MRP. So the people in the location physically, they are the MRP, we are just consult and supporting them. The other way of letter agreement, we take over. We are the agreement as we are the MRP people. So we can sign all the documents. We can go even for palliative decision like DNR, we can sign it, we can counsel, we take over all of that. So we just easily, we write it when they start the service, how is the agreement shaped, then we process and we overcome.
I think we have to close. By the end, I'd like to thank the audience on my behalf and on behalf of Dr. Imad, the moderators, and also on behalf of the speaker. Thank you for attendance and good luck.